Here is a case of retroperitoneal fibrosis primary diagnosis. So we thought we will mobilize and put the omentum, but at one area expectedly as RGU, very severe narrowing was there, half centimeter to 1 centimeter. Then we have to clearly mobilize below 4 centimeter, above 4 centimeter, where it was inflamed and dragged medially towards the aorta. So after that, vertical incision is given. Instead of doing end-to-end anastomosis, we have done buccal mucosal graft ureteroplasty, sharing the same case. Retroperitoneal fibrosis, robotic release of ureter, and BMG ureteroplasty. Honestly, I have not done many retroperitoneal fibrosis. I was thinking in this 38-year-old male patient, retroperitoneal fibrosis, left hydronephrosis, repeated DJ stenting from 2024, course of steroids complete, no response, planned RGP and ureterolysis. Narrow segment was there at the LT level. Exactly at that area only it was dragged too medially. That was the history. These cases are not common. You can see the ureter at the middle segment is dragged towards the spine. There is a lot of inflammation at this level. You can clearly appreciate very close to the, this is the area where it was stenosed. So now the plan is to focus on that area only. Ports are put according to that area only. Robotic SSA mantra done. So we tried to mobilize. We expected, actually, as I said, I don't have more experience with RPF. I was very vigilant. I was doing very slowly that how much fibrosis will be there, whether I can mobilize the ureter or not, is will be an injury to the aorta, like that. Apprehension was there. But as the I moved, it moved slowly, very well, without any adhesions. But the problem is I could not find the ureter for a long time. See, on the psoas I am there, on the psoas medial border I am there. I thought every tubular structure is a ureter, and I applied gauge piece, went slowly. Gonadal vein was so big. Medial end of the psoas also I could not see. Now slowly inflammation started. See, then I felt confident that our diagnosis is correct. See the gonadal vein. After that, see, ureter is not seen. Then suspicious area ureter is seen just besides the aorta. So I was not at all cutting or using coagulation at all. Very slowly I have done. See, I tried to lift, I tried to dissect this side, this side. It's like a hard tubular structure. See, assistant lifted. Every step I was afraid, in fact. So anyway, ultimately I found it is ureter. I found above below it is supple. Then I got confidence that I am dealing correctly. So slowly, little bit tissue, I started cutting. Very minimal coagulation I have done. I kept ureteric catheter to identify. That was no use. This is the area of the stricture. Ultimately, that was dense fibrotic area. Then I have to sacrifice the gonadal vein. This is the lower pole of the kidney. Gonadal vein, why I sacrificed is, see, this densely adherent to the psoas. So even though this area can do my job, I thought for buccal mucosa carefully putting, this may not be. See here, first time I held, gone closely removing. So clearly the waste is there here. So there I opened and ureteric catheter is seen. Ureteric catheter is seen. You can see that. So then I realized that we should not do any more damage to that area. And I also want to see the suppleness above more. So I have to sacrifice. Otherwise, I might have done. But I want to confirm, is there any other plaque? Because a certain amount of inflammation was there here also. See the, so wide excision of the gonadal vein, because he completed his more than 40 years. So I sacrificed that. And fat and all I removed because I don't want any obstruction in my view. And now it is clear. Now I open vertically up like this. Then I could clearly see nice mucosa, and with the left hand I opened continuous urine is coming. That means at least proximally I don't have obstruction. Distally we cannot say, but in RGP ureteroscopy nothing was there and ureter was supple, and So I don't want to take any mobilization of the distal part. That is a controversial issue. Tomorrow it may come. Now buccal mucosa is taken a little longer than, because you never know. So I have taken little long. I made a V cut in the lower part a little bit. So this fibrous tissue I excised. Very carefully I have sutured. Actually I have taken a lot of time in this case. From beginning, whenever you are doing unusual case, better to do slowly. I have taken a lot of time in this suturing because it's reconstructive. Nothing should go wrong. So reconfirming which is outside surface. I have taken generally I don't use this Maryland type of instrument in robotic, but because the grip is very good, every time mucosa edge is everted, the urine was coming too much, as if it is diuretic phase. So constantly suction and gauge piece kept so that the buccal mucosa doesn't get sucked with the suction. See, I was sucking like this. This is the important point. Otherwise, buccal mucosa repeatedly, if it is sucked, it can get damaged. Forget about sucking into the suction tube, but we should be careful. So like this, it's very useful gauge piece. Now I have cut here. The scissor was little rough, probably many uses. Then I could ultimately cut it, taken it out according to the bread. So this is the picture. Now angles, again I have taken lot of time. I came out in and kept there. Now I have taken another suture. Outside in I came. This is important bite. Should not take posterior wall, and very closely to the previous bite I have taken. So both knots I have knotted so that they sit properly at the angle. This is very important. Now this is the angles are over. Now I thought I will come from below up so that the knotting will happen in the middle. Avoid angles knotting because they may stricture if you don't do proper. In the middle, they fall lie will be good. So like this, we have sutured. This is the suturing. So now this is the little bit of adjustment. Before that, we have to put the stent. Robotic stenting is very easy because any angle it can come and go, and ensure that you pass adequate into the kidney. Now I came from above. 3-4 sutures I have used less length so that nice fall will be there and reconstruction will be good. So these are the main points. See, this small area I have cut it. Small area. So little dog ear always will come. So again I have to use a robotic scissor to finish the dog ear. This is a little bit of your happiness. Not really, may not matter. The edges will heal anyway. Like this dog ear without dog ear. One bite this side, one bite that side. I have taken. Ultimately, see, one bite this side, one bite that side, so that you end up in center clearly without overlap, without dog ear. Fall should be good, and every time it is not V-lock, so you have to stretch so that buccal mucosa doesn't loosen from the edges. Otherwise, the concept of buccal mucosa in the ureter we are enjoying and results are good. How the imbibition happens, every time we get the momentum. Because it is left side, it has to come from the mesentery. Mesentery was nothing here. Directly with scissors it is cut, and A momentum is pushed, and the colon is retracted, and momentum is placed there, wrapped there, and sutured also, so that this momentum is sutured around the buccal mucosal ureteroplasty region so that it will give. We will share the surgery results as we have started now, as many people are asking what are the results. Yes, it's very important that it may stenoze, it may cause hydronephrosis, retroperitoneal fibrosis can occur. So that's what we wanted to give the message. Thank you.